they just will move to another pillar of the earth from Belize to Portugal. You know, the credential of Dr. Dr. Antonio, and this is very important because he's basically training surgeon, but he will speak about very important topics because I engaged 1 or 2 times in something like this, and I don't have idea as anesthesia about what we'll do for this management of that. The credential of Dr. Antonio is he have a European Master in Disaster Management. And this is a very important, especially during time of disasters, during time of like even epidemics and disasters, how to treat this disaster. And they have also a fellowship of critical care medicine, and he's a surgeon also. A fellowship of American College of Surgeons. Dr. Gandra is a faculty of several courses in critical care, and also not just critical care in emergency and trauma, something related to his specialty and professionality. And he's an author and editor for several books. And also he is a part of committee in many society. And now he's a staff officer of Portuguese Army. He's an army, working as an army man and also a medical doctor. And it's very difficult to get the 2 jobs at the same time. As he worked as a medical doctor and as an army man, he worked in several catastrophes. And you know that I don't know, you are lucky or not lucky to work in a catastrophe, but because you are a professional, you can manage. Not just to study, it has a practice in his professional way. So the lecture will be a nice educational tool. You will link it by real practice, and we have a real practice. Also, he worked in pre-hospital emergency, in emergency helicopter, and the medical care. I never ride helicopter, but this is a very good job to make a medicine in helicopter. You know that for attendee below 18 years or have a heart, what's called a weak heart, we ask him to leave now as a safety coming first. As Dr. Gandra will speak about mass shooting as one of the disaster events. At the end, massive goal doesn't require massive action. They require consistent action, which will done now by Dr. Gandra. Now the field and the weapon for you, Dr. Gandra, you can start your shooting and your presentation.
Well, first of all, thank you for the invitation to be present in this online teaching. So most of us are used to stay on the hospital, and we don't think that to give an answer, we need to have all the system put together. Well, in the States, they started to have lots of issues about the mass shooting. But to have a definition, they don't have just one. So depending on the agency that speaks about it, they have 3. The Congressional Research Service says that a mass shooting as an accident, you should have 4 victims. For the FBI, you need to have 1 active shooter with several victims, but all the non-governmental and media organizations, they say you will have a mass shooting event with 3 or more victims. As you probably know, in the States, they started having lots of problems since the first one, the most famous one in Columbine, in high school, that a 12th grade, the senior students, 2 of them murdered 12 colleagues and 1 teacher in '99. Since then, there have been several mass shooting events in schools, and not only in schools, but normally the school events are more, well, they pay more attention, and the media gives a better and higher cover of it. But sometimes they also go to the nightclubs. For example, in 2016, there was a mass shooting inside the pulse of a gay nightclub in Florida. And this well known in 2017 in Las Vegas, this one, you had a shooter that was in the Mandalay Bay Hotel, and he shot and killed 60 people and wounded 411. But with the stress, and all the movement, there was a total of 867 injury in total. And the last one with more impact was in the high school, once again, with 17 people killed and 17 other injured. So in the States, and well, they started having the idea to have school drills about mass shooting. And at this moment in the US, 95% of schools have this kind of drills. To have the drills, and the objective of the drills is to find action plans and to drill them so everybody knows what to do, and the students have to know the procedures and what to do to respond to an active shooter. These protocols also are depending and to train the rapid response, and our students will help and all the people which have disability conditions. But what they started to see doing the drills, there were a lot of concerns about the stress the students were having. Most of the drills, they didn't said it was a drill, or if it wasn't, so they trained and they gave the alarm. So many of the students started having some issues with stress, and there were lots of concerns from the educators and mental health professionals. So what they said, to make the drill on schools or whatever, they should be announced in advance to take proactive measures to reduce the students' anxiety. You can imagine if you're in a school or whatever, and someone says you have an active shooter, everybody will stress. So when you have many drills on this, the levels of stress were very high among the students. So how to do in schools, and this study was about schools, but we can do it and take what they learn about the school drills and take to the other places. So one of the things is not to simulate an incident that really happened. So you should put the drills and put up a drill, but nothing that has already happened. You should involve school personnel, including school-based mental health professional, and you should have a couple of drills with trauma-informed approaches to address students and educators. And it should be evaluated for efficacy and impact on students and staff. The thing is, most of the drills and mass call drills, even in our hospitals and services, normally you put a drill, you end the drill, and everybody claps, and it was an excellent drill. But it's not very usual to be sincere about it and to have a correct evaluation how it was and the points where you can grow and learn how to do it. It is very important to learn to help the others, especially the injured people and the people that have disabilities. In mass shooting, we know most of the victims will be trauma victims. So the most important thing is hemorrhage control. So there are many programs as Stop the Bleeding or whatever, and they teach you how to apply tourniquets. In the States, near the AED, you start having kits with tourniquets and other measures to stop massive hemorrhage. So you need to, so you can act properly, you need to learn how to do it, how to stop the mass bleeding. In our hospitals, after the Orlando Regional Medical Center was faced with multiple challenges, as you can imagine, the hospital that was near this incident, they didn't have so much time to get prepared. So They started using the incident command system. They have trained already. And the hospital, because of this, was able to mobilize quickly, receiving 44 patients, 9 of whom died shortly after arrival. In this point, it's very important to do a correct triage, and in this case would be a mass casualty triage. So everybody should be trained in mass casualty triage. Is very important at the different levels in our hospitals. So the hospital had undergone an active shooter drill only 3 months before the shooting. So, of course, this helped to give the correct answer. And to do the things correctly, you should do the drills as realistic as possible with everybody that is involved, the different agencies, police department, fire department, emergency medical, and the volunteers that normally work on it. If you do as realistic as possible the drills, if you have an event, or even if you have not a mass shooting, but a catastrophe like we had with COVID, all of this will prepare to receive and to prepare to different realities in catastrophe. The University Medical Center of Southern Nevada was able to handle the large influx of patients after the mass shooting in Las Vegas. All the drills include training for the mobilization of significantly increased surgical services. So it is possible to adapt some of our units, some of our trauma rooms to hybrid rooms, or even to operate on them. So you should have in our hospitals the knowledge how that is possible, to know where you can do it, speak to the surgeons, have everything ready to do the first control of the bleeding, the first trauma control as soon as possible in the most places that you can work on. We cannot forget the emergency medical services. They normally do the first triage in the pre-hospital, but we also know that the first wave is not the wave that was triaged. The first wave is people that can move and go by their own means to the hospitals. You must have the training on the triage pre-hospital system. Depending on the system that you work, you can have police department, fire department, or even the emergency medical system doing it in the site. But you cannot forget that in hospital, you should do a mass casualty triage also, and to prepare for it. And we know from the pre-hospital that the transportation is important for reducing the likelihood of mortality. But it's not only to transport to the hospitals. We need to know where to take them. The dispatch center cannot send everybody to the same hospital, or the hospital won't support it. The thing is, you should divide the victims depending the gravity of the injuries and to several hospitals, and you should have a regional response and not only an hospital or the nearest hospital response. For this, it's very important to have a good communication. It's important to have a good dispatch center and the communication between the emergency medical system and the hospitals or the command center, depending on your reality. The second wave effect, this is a phenomenon that we know the less injured arrive before the patients in need of critical care, because these ones went by taxi, by their own means, so they will be the first to get to the hospitals, and these ones will go to the hospitals that are nearer the incident site. For this, you should be prepared to do the triage and to be prepared to have areas for the less injured to wait to get the needed help. So the first is signaling the hospitals near to an event that they will be receiving an influx of patients. You should have your plan, your drills plans, your MASCAL plans, and everybody should know and have trained for it. So as soon as the hospital has the communication, as soon as the hospital can be prepared and to check everybody and to call everybody to work and to prepare the arrival of all these patients. And of course, if you can, you should start having some stabilization en route. The second major form of communication is the need for a receiving hospital to process and disseminate information about victims quickly to their families. As you can imagine, with all the stress, if you have earthquake or whatever, everybody is worried about their families. So if everybody phones the hospital or goes to the hospital to try to know something about their relatives, you'll have another disaster because the communications will go down and you won't have time to deal with the stress of the family of the patients or to give correct information. So to have the circle and even the ICU response, it's the preparedness circle. So you should have the planning of it, to think about it, the limitations, to have the plan of what is more probable to happen in my area, then to organize this plan, to train. After the training, we can know the things we need. So we should equipped with what we need. Then we can exercise again, evaluate how it was, and then taking the correct action. With this, we'll try to be as prepared as possible. Of course, we know as definition of a catastrophe, a mass shooting, earthquake, whatever, or even COVID, definition of a catastrophe, that is that you are not ready for it. The thing is to be ready, to be trained as possible, knowing we are going to have it. The ICU normally is the bottleneck of the hospitals. So it's very, very important to have exercises, MASCAL exercises, and surge training capacity of the ICUs. We had it for COVID, and some of the courses, some of the training the ICUs as before, that has allowed us to increase the preparedness and to increase the capacity of answer to the critical care patients. But it's very important for this to use strategies to conserve, substitute, adapt, reuse, or reallocate, and the triage of the scarce resources is very important. We should try to treat and to receive only the patients that have a better ability to recover. When we have scarce answers, we need to choose very well the ones that we are going to try to help. The critical care leaders must provide leadership preparedness. We never know who is going to be on shift. Everybody has to be in state of health and to know how things work, so they will be ready to give the response and to orientate the people that are on shift. The planning has to include system level and site level communication. The most hard thing to have and to work with a MASCAL incident is communication. That's one of the certain things that will fail. So it's very important to communicate and have the sharing of the resources. To have the preparedness plan, this requires a planning for surge capacity of staff, ICU space, and supplies and medications. We also know that some of our hospitals in normal days are overwhelmed. We don't have all the medication that we need. We don't have all the staff, but we also learned in this year and a half that well planning, it's halfway to give a better answer. And we saw with COVID that it's possible to do better with less. So part of the training is very important to do better with less. We know that the increase of the flow on ICU, sometimes it's necessary to go 120% to 200%. In my hospital, we had to multiply by 3 the ICU beds. And if someone asked 1.5 years ago, this would be impossible, but it's not impossible. The thing is to try to understand how our hospital works, how our emergency department works, and then to pick up a plan by levels. Of course, you don't need to go to the highest level, depending on the mass call event or the mass shooting event, and then to give the adapt answer, and if necessary, to go one step further. It's very hard to do the triage in ICU. It's very hard to have a systematic criteria to admission to an ICU. And in mass casualty on these events, it's even worse. We don't have time to assess as good as we should. And we have a very limited number of beds. But these plans should be known and done before, and with the knowledge of everybody that is involved in the ICU. Depending on the crisis level event, once again, we have to know to whom we are going to give the resources. The triage is a process that includes narrowing inclusion to mechanical ventilation and need for vasopressors or inotropics. And it's very important to establish exclusion criteria based on the low probability of survival and short life expectancy. And this decision shouldn't be done, or this algorithm shouldn't be on the day. It should be prior, it should be part of the plan. And every doctor and nurse that works on the ICU or in the different departments, depending on where you're going to do the plan, should know about it and know the criteria that won't depend on the doctor, but are defined before. So in summary, what needs to be done? When a mass shooting occurs, there are several critical steps that are important to do. In this case, understand that firearms injury is a surgical disease, and that the faster someone who has been seriously shot gets to a designed trauma center hospital operating room is the better, because that's the treatment for it. We should conduct large-scale trainings involving police, educators, and the public in the hemorrhage control, mass bleeding control, and try not to expose young children to trainings designed for adults. The traumatic events of the trainings can affect them afterwards. When arriving to the scene of a mass shooting, police, emergency medical systems, and other first responders should form an integrated command center, and this one should be trained already. It's very important to have the system trained before things happened. And to the extent possible, transport of serious injured people to a trauma center hospital should be a first priority, but whichever public safety professionals are first to arrive on scene and can safely transport. And this one will happen after a correct mass call triage. For this, it's necessary for all the professionals involved to be trained in systematic procedures for actually triaging people in mass shootings or triaging mass call victims. Simulations and virtual trainings can help prepare these public safety professionals for mass shooting events and triage. And with proper training, equipment, and support from police, EMS, professionals can safely be brought into the warm zone near a mass shooting and begin to transport and administer medical support sooner than they would otherwise would be able to. So you need to put the people safe, because in this case of mass shootings, we're not sure how many shooters we have. So after you got the people to the victims to a safety zone, you should try to prioritize and start stabilizing them as soon as possible and do the evacuation. All hospitals should follow the team-based model used at trauma centers and be well prepared in advance to receive these patients. We know the wave and in all mass call works the same way. The first wave normally is the less injured ones. We will have to be prepared to have a place to keep them and wait for the serious ill patients. It's important to have a closed channel, public safety communication systems that have been tested and prepared in advance. And this will help to the communication to everybody and to know the channels, so this will work. We know also that hospitals should not only be aware that they are likely to experience additional waves. We know that they should be divided by several hospitals, and the hospitals have to speak between them. Hospitals should be prepared to a crisis situation and give adequate responsibility. And drills are fundamental, because it's not only having the material or the people. They should train and train as real as possible. Hotlines can be established to better address concerns from families, friends, and the community to prevent overburdening of local communication systems or even at the door of the hospital. So the disaster risk management cycle, we can divide it. And the most important is to be prepared as possible. You know, depending on the place you're at, it's impossible to be prepared for everything, but you should try at least to have a risk assessment. Then a damage assessment to stabilize and provide that when a disaster occurs, and when the event occurs, you should try to prepare the recovery as soon as possible. And it's also very important to have the mitigation part, where the same versus hot zones, they are very important to reduce the amount of loss by identifying potential problems and mitigating them in advance. So this is very important to prepare, to control when you have it, to plan also the recovery and the mitigation of the event. Thank you very much. Obrigado. It was an honor for me to be here.
Thank you, Antonio. It's very interesting lecture to me, because I returned back by memory. I was working in Hajj in Saudi Arabia, and Mika triaging it's called the drill. They bring about 150 soldiers as a patient, and everyone have a color code, and we manage the patient in OR, and it will be very easy, because after that we got about 50 patients already in crash, and we can manage. But really, you open our eyes today about the pre-hospital management, because we're never thinking about this. We're thinking from the patient coming to OR or just coming to emergency. And thank you very much for opening the eye for this other part, which is major part, and is very important, because you are deficient with resources, staff, and even time to do your decision. And as you said, that drill is very important. And I think at that time we make many drill. Without drill, you can't learn. So, and also to work in with deficient staff, time, and the resources is very important to learn to work like this, not a luxurious life all the time. And I think this is disaster management medicine will be in the future a very important topics because you can save a life before the hospital. Again, thank you very much. I'm very interested for this lecture, especially to learn from other perspective, other vision from another person. You know that we have a small room for question, so we can get in some question from our colleague. The first question, as usual, from our eminent colleague from Qatar, Dr. Mohammed Sulaiman, is a very good member of MEGA Online Teaching. He said he asking about the role of robots and the drones in the management of mass shooting. Any idea about that?
Well, in every mass casualty event, everybody is trying to put some technology of it. Of course, the drones will help you to do a recognition of the place, and with that, you don't need to worry about exploiting and the safety of it. It's a drone. If there's any problem, it's not a human life. So they're being used not just in the mass shooting, but in all mass scale events to try to look for people and to try to realize what's really happening. But there are several tests in mass scale, namely to do the mass scale triage, to try to identify if, for example, in the case of taking to the mass shooting in Las Vegas, that you have more than 800 injured. How is it possible to do the triage and the identification of the 800 with handpicked? It's very hard, and you'll lose someone probably. So, but we also know in mass scale or earthquake or when you have a shortage of electricity, all these means probably will fail. So you should have the two levels. The one that you don't depend on any technology because you can fail for many reasons, and the events that you can get and to have some support from them to use it. But of course, the technology and the drones have a place on it.
The second question, I think this is an opening a gate for a very important question. Do you think that the people working with an emergency like ICU people, emergency people, and anesthesia, which make it emergency, need some training as a part of their training for pre-hospital training for mass shooting or just a disaster management and how to do it? Because really, I feel that I'm very young in front of what you said, because I am a very deficient in this one. And I think most of our colleagues like this, and this is very important time. And we know that in Toroma, we have a golden hours, and this is your golden hours. If you don't save a life in this time, it will be a problem. Do you think it may be an open a gate for discussion about this training for these people?
You did two different questions. The thing, depending on the country and the reality that you work on, you can have doctors and nurses that are more in the hospital and don't think about the pre-hospital. In other countries, for example, mine, that doctors and nurses are in the pre-hospital, and that allows you to understand better the system and to understand how the patients get to the hospital and how things work. And I think having one system altogether, it's easier to improve it. But if you live in a country that you don't have even physicians for the hospitals, well, it's better to have paramedics than to have the physicians or the nurses in the pre-hospital system. But you can have medical personnel doing the coordination of the pre-hospital, and you don't need to have so many doctors to do that. The other question is that if everybody should have some preparedness or some knowledge of mass scale events. I think so, of course. And you saw it now when people came to your hospital. I don't know what happened, but for example, in my hospital, operating rooms stopped working and they were turned into ICU beds. And this, as an anesthesiologist, you have to get out of the box, try to start taking care of patients that come directly from the emergency room that's not to be operated, and you have to take care of them for a few days, for example, and not for only a few hours that it was expected for your normal work. So I think a MASCAL plan should involve everybody. And of course, the anesthesiologists are very important of this because they are used to the emergency, they are experts in the airway, and they are also used to ventilate people. So in case of necessity, you're one of the most important physicians in the hospital. So everybody should be part of the plan, but there are a few ones that are able to give a better help than the others.
Last thing, not a question, just a request. We need to see you again in Mega Online online education and in disaster, not in disaster, sorry, not in disaster, in the discussing a part about trauma or just other disaster mass casualty, because really we are deficient in that and we want to learn from you. Thank you very much, and thank you for everyone. Thank you, Dr. Doyle, and thank you, Dr. Pedro, and thank you, Dr. Gandara, for joining us today. And the room is for Dr. Saad. Thank you very much.